Good morning, everyone, and welcome to today's webinar. I think we may have some more folks joining, but we've got a lot of great content, so I think we're going to get started. Today's webinar, Thinking Past the Pandemic, Dismantling the Stigma Around Mental Health. My name is Maddie Issleib, and I am a member of the Associate Board at CommunityHealth and a manager at West Monroe Partners. For those who don't know, CommunityHealth is the largest volunteer-based free health center in the United States. We provide primary and specialty care, prescription medications, mental health and dental services, health education, and lab testing on the west side of Chicago. Our patients have no health insurance, and we provide all of our services to them free of charge. We do this with the support of over 1,000 volunteers, partnerships with dozens of institutions, and donations from generous people like you. So thank you for being here, and thank you for supporting CommunityHealth. Today's program is part of CommunityHealth's ongoing All in Chicago campaign. The goal of the All In is to bring together leaders from many different industries and segments of our population to talk about how we can work together to ensure every resident has access to the right care in the right place at the right time. CommunityHealth has been convening all-in events discussing access to healthcare in Chicago since 2015. And we're thrilled to be hosting our all-in series this September with more opportunities to engage people in our collective efforts to enhance access around the city. I encourage all of you, if you haven't already, to visit our website at allin-chicago.org to stay up to date on all of the events.
Thank you, Maddie, for the wonderful introduction to CommunityHealth's amazing work for All in Chicago campaign. My name is Meghan Phillipp, and along with Maddie, I have the incredible honor of serving on CommunityHealth's Associate Board, in addition to my role as the Executive Director of the Healthcare Council of Chicago, HC3. This morning, Maddie and I have the privilege of moderating a discussion around dismantling the stigma of behavioral and mental health. The COVID-19 pandemic and subsequent economic downturn have contributed to a complex array of individual and family stressors and have dramatically increased the need of treatment and access to mental health services. Even before the pandemic began, access to behavioral health prevention and treatment was limited. Stigma continues to be a barrier to care, and providers are still struggling to sustain needed services due to workforce shortages, poor reimbursement rates, a lack of parity in enforcement, and other policy-related issues. Today, we are joined by 4 experts that are leading the charge to advocate and provide solutions to address some of these challenges. Before we dive in, I have 2 housekeeping items. This morning's discussion is being recorded and shared on CommunityHealth's YouTube channel for later viewing and sharing. And as we hear from today's experts, if you have any questions, please feel free to use the chat function, which will be seen directly by Maddie and myself, and we will do our very best to incorporate those throughout the session and during our Q&A later in the program. So without further ado, we'd like to officially welcome our panelists to join us by being spotlighted. So welcome Dr. Rukhsana Chaudhry, Director of Mental Health Programming at American Muslim Health Professionals, Ornella Razetto, who is Social Services Manager at CommunityHealth, Maddy Reinert, Senior Director of Population Health and Mental Health America, and Doug Williamson, Senior Vice President and Deputy Global Chief Medical Officer and Head at the US R&D at Lundbeck.
Great. Well, welcome to all of our panelists. As we dive into today's discussion, I'd love to have each of you start off by sharing some general thoughts on where we are today. A study published this past spring by the Kaiser Family Foundation showed that approximately 4 in 10 adults in the United States have reported symptoms of anxiety or depressive disorder throughout the COVID-19 pandemic. We also know there have been many disruptions to school-based programs, challenges with broadband issues affecting digital services, and other complications with reaching people in need. Much of what each of you are working on, thinking about, and trying to address are these issues. We'll start with Doug, followed by Maddie, to share some of your global and national perspectives, and then I'll turn it over to Dr. Chaudhry and Ornella to provide your more localized community perspectives. So Doug, if you want to kick us off.
Sure, thanks, Maddie, and hello, everybody. I think what we've seen, following on from the waves of infection and illness that we've seen with this pandemic, there's been a literal tsunami of mental health challenges that are going to have long-lasting and adverse impacts on individuals, their families, and their communities. So for some people already living with mental health challenges, the loneliness, the isolation, the grief, the economic insecurity, and the stress is certainly resulting in a worsening of their symptoms. But we're also seeing a historic spike in new mental health concerns, with as many as 40 to 50% of US adults reporting that their mental well-being has been negatively affected by the pandemic. So one opportunity here, I think, has been the increase in use and availability of telehealth and online services that we've seen during the pandemic. But the challenge is the realization that many people don't have access to them. They don't have iPhones or they don't have broadband. So there's really an increased need for a targeted community response, and also an ongoing challenge to reduce the stigma around seeking support for stress or other challenges to mental well-being.
Great, thanks so much, Doug. Maddie, if you want to go next.
Yeah, absolutely. Thank you so much, Megan and Maddie, for the introduction, and thank you for giving me the opportunity to be on this panel with everyone doing such incredible work. I do think nationally, just to echo many of the things that Doug just mentioned, we're seeing a dramatic rise in the number of people experiencing mental health concerns, both throughout 2020, but also into the first 6 months of 2021. So we have seen the Kaiser Family Foundation and CDC data showing the rise in the percentage of adults with recent symptoms of anxiety and depression. They've also reported an increase in the percentage of those reporting an unmet mental health care need as well. And we've seen this in our own data at Mental Health America. We run an online mental health screening program, which is a collection of 10 free, confidential, and clinically validated screening tools that allow people to check on their mental health concerns online on their own, just to increase that access. And we saw an explosion of people coming on to take mental health screens through that program. Historically, we had about 1 million individuals take a screen each year, and in 2020, that number increased to over 2.6 million people. And already just through the end of May of this year, we have had almost 2 million people take a mental health screen there as well. So in our data, we've also seen that not only are those number of people taking screens increasing, but the percentage screening with those moderate to severe symptoms has increased. And that's especially true among young people, both youth and young adults. So of those 2.6 million people, nearly 1 million were under the age of 18. And they were much more likely to screen at risk for depression and anxiety than any other age group in our data. I also think it's important to note that while we're seeing a rise in mental health concerns across the population, we're also seeing a disproportionate impact among marginalized communities and communities that were already underserved or even historically harmed by the mental health care system. So symptoms of depression, anxiety, and suicidal ideation increased more for Black, Indigenous, and people of color than for white individuals across the pandemic. So we're seeing a mental health crisis that is truly growing. It's not slowing down. I do also think that we're getting more attention and more of a conversation going about mental health than we've had in a long time in Congress and in the media, but also societally. But because the numbers are so large and there is such a huge unmet need that we're seeing, we really do have this need to act quickly. And I think that's why this conversation is so important today.
Great, thank you, Maddie. Now I'll pass it over to Dr. Chaudhry and Ornella. If you want to give a more localized community perspective, that would be great.
Thank you so much for that. And I I think that, some of the comments today already are speaking to the issues we see nationally and then, across communities. And then when I think about our community, I think one of the most important things that we're coping with and dealing with as a whole is dealing with the aspect of stigma within the community of mental health and mental illness. But then beyond that, really experiencing crises at the forefront for the community. And that really revolves around understanding suicide and understanding the impact of depression in the American Muslim community, especially after COVID. And we've really seen multiple events across the country in local communities. One particularly that was very shocking and jarring occurred in the Allen, Texas community, and where there were signals and signs of two young people suffering and dealing with issues of depression or related, but then really not seeing that happen in the community as a whole and not being able to recognize those signs. So I think we're learning that suicide and depression is something that the American Muslim community really needs to kind of hone in on as something that we're experiencing post-COVID and of course occurring before, but really putting our laser focus into, since we've had events like in Allen and we've also had events in the northern New York, New Jersey area. And so these are kind of local events that have kind of shaken our community as a whole and putting us into a place of recognizing that we too suffer at that same level of mental health issues and illness as other communities, but also helping others to understand that we sort of are lacking those resources and connections to those systems that can help those individuals get the treatment they need that's beyond cultural competence and religious competence, but a real deep understanding of the American Muslim community. So that's where we are. And I definitely want to elaborate more as we can on the local experience that these communities have conveyed to us.
Yes, and I'd like to add, and I just a little info with who I work with. I work primarily with a largely undocumented immigrant community, but we work in general with low-income adults who are uninsured. And so with this, we serve a largely already disenfranchised community, right? And with this, I'm sure we're all, aware and agree with, the realities that this just heavily impacted those that already had so many barriers, to begin with. And, the cumulative stressors of job loss, for example, with my community as an immigrant myself, my community just, what do you do when you can't qualify for the benefits that other people have? What do you do when the doors are closed to you because you don't have a social security number, because you can't find an interpreter to help you? And just how this pandemic has really just worsened the struggle we already were facing prior. I mean, I will say there's nothing like a pandemic to bring this to the forefront. However, it's this idea we've known we've had this problem. It seems to me like the rest of the world is kind of catching up to these problems. So it's really interesting where we go from here, because I see so much, and I'll touch on this, with other points that I hope to make, but I see this larger issue of mental health, it's really truly exacerbated by other factors, right? Financial factors, being away from family, how we're dealing with loss, if we're able to deal with loss, especially when we can't travel to see relatives who've passed away. Just so many issues that I would say are not specific to mental health, but aggravating the current mental health crises that folks are going through, because I think it's just impossible to separate just the lacking infrastructure of supports that folks need for mental health, right? We can throw all the counseling and psychotropic meds at a problem we can, but if we can't help with housing, if we can't help with work, if we can't help with schooling, are we really going to be able to make a difference? And I do hope that as a world, not even just as a local community, we're able to really understand that we have to work with all of these factors to improve the larger idea of, well-being and mental health for all communities. But again, specifically how this touches disenfranchised communities, even more so because we've been going through it for so very long.
That's so very true, Ornella. And Maddie, you said in your comments that we have seen an uptick in minority communities specifically, which echoes what Ornella is saying. So what, in your opinion, are some of the ways that the pandemic has highlighted the lack of infrastructure to address mental health concerns? And what are some of the solutions from Mental Health America? And then, as you work with different partners, what are the types of things that you're seeing? And I'd welcome anyone after Maddie chimes in to add other solutions that you're working through.
Yeah, I think one of the largest things the pandemic has highlighted in terms of lack of infrastructure is just how large the mental health workforce shortage is, especially when we start to look at these increasing numbers of individuals struggling with their mental health as a result of the pandemic. So on average across the US, there are about 416 people for every one mental health provider. But that varies a ton state to state. And in some states, there are more than 900 people for every one provider. And that's at the state level. That's not even looking at counties where there may be no providers available. And that has been improving slowly over the past few years of data that we have. But now, again, as rates of depression, anxiety, and other mental health concerns have dramatically increased and are still increasing, the need for mental health care will greatly outpace these slow additions to the workforce. And that has a negative impact on providers' mental health as well, right? Because they're experiencing heavier workloads and greater impacts of burnout. I think, again, we're going to see this in schools because of the really large increases in mental health concerns among youth. So as kids go back to school and many more are experiencing mental health concerns following the pandemic, schools are already severely underfunded. There's not sufficient federal funding for local education agencies to meet the mental health needs of students already. And lots of schools don't have mental health staffing to be able to address that need. So some of those ratios, again, the National Association for School Psychologists recommends a ratio of 1 school psychologist per 500 students for comprehensive mental health services. But currently the national ratio is about 1,200 students for every 1 school psychologist. And again, a lot of variability among states, with some states having about 5,000 students for every 1 psychologist. And those are ratios just to any one mental health provider. So that's not even mentioning whether that provider is representative of the community they're serving, or if they're providing culturally or linguistically appropriate care. I also think, as Ornella mentioned, the pandemic has highlighted a lot of the structural inequities that exist in terms of mental health infrastructure that have always existed, but really, really were highlighted during the pandemic. So we at MHA, we recently released a report with Lundbeck mapping our data from our screening program from individuals reporting frequent thoughts of suicide or self-harm in 2020 throughout the pandemic. And we're able to identify counties in the US in greatest need of mental health resources right now. And we found that many of the counties we identified as having a large number of individuals experiencing frequent suicidal ideation were also counties that had really significant barriers to accessing care. So high rates of closures or unemployment during the pandemic, where people lost their health insurance coverage and couldn't afford the extremely high cost of mental health care. There were also areas where there were no mental health clinics nearby, or there had been, but they had also closed during the pandemic. So in many of these areas, there was absolutely no mental health infrastructure. So the pandemic really highlighted that the same communities that were disproportionately impacted by COVID-19 itself, and the secondary impacts, like effects on food, housing, and economic security, all of which drastically impact your mental health, are the same that already don't necessarily have access to mental health services. So those are some of the largest infrastructure challenges that we saw.
Yeah, and maybe, and if I can just build on what Maddie's saying. So I think the resources are extremely limited. We've been working in this area of mental health care for more than 70 years because we're focused on brain disorders, but the sheer scope of this challenge is going to take new approaches. It's going to take innovation, and Maddie mentioned one of them. We've had a long-standing partnership with Mental Health America, and one of the things they have is a huge database, as she mentioned, of screening data, from their website, which gives you the potential to observe this crisis evolving in real time instead of looking at the after effects a year or two later, and that allows you to shape the response accordingly so that you can focus the community level support down on the populations that need it most, almost down to the zip code level. So just as cutting edge digital tools and analytics are being used to inform the community response to the virus, we're hoping that some kind of national mental health dashboard could enable real-time insights and highlight mental health hotspots, if you will, in a way that improves the response to mental health needs by allowing it to be more focused and more efficient. And hopefully this could also address disparities that diverse populations face, and allocate some of those limited resources more appropriately instead of trying to spread those resources across everywhere. But this has to go hand in hand, as I think Maddie also mentioned, with raising awareness about the need for community supports and interventions. It has to go hand in hand with policies that improve access to those resources. And perhaps most importantly, it has to go hand in hand with education and awareness to help overcome the stigma associated with mental health challenges. And perhaps Ornella or Dr. Chaudhry can comment on that.
Yeah, I mean, Ornella, in some ways, there's a collective experience associated with the pandemic. Have you seen some of the changes in openness that patients are experiencing to talking about this? And what are some of the other challenges that Doug sort of highlighted that you're trying to address through some of your work?
Yes, absolutely. So one of the things, I will say one of the positives, there haven't been much, but we all have to build on the positives that we do have, is this collective idea of I'm not alone. I will say it is not specific to necessarily depression or anxiety. Someone saying, oh my God, yes, I have depression. I have this thing I see on commercials and I hear people speak up, but there is this idea that when other people are saying, I'm feeling sad, I can't sleep, I can't go to work, I can't talk to people. I mean, the work piece a little bit different in the pandemic, but this idea, people are finally able to connect their symptoms, although not naming them as symptoms, right? Just like what I'm feeling, right? What people are feeling, they're connecting to this larger idea of like, oh, these feelings I have are these things called symptoms of depression or of anxiety. And people, because it is such a massive scale with which people are beginning to feel these things, and are understanding that this is a collective of like, oh, we're just all going through the same thing, it lends itself to this openness to share this. And I work in a clinic, which is really important to share this with medical providers, because especially the community that I work with, it is not common to share this with family and friends for shame of being judged, for shame of being told you're weak, for many shame reasons. And if at least someone is able to identify, I thought I just wasn't doing enough for me, I thought I was just not strong enough, rather than no, it's the, oh wait, it's not me, it's everything that's around me that's happening to me. And with this, more folks are apt now to speak to their providers of like, listen, I'm having these problems. I will say, however, on that note, I personally can speak to this. I have had so many more referrals over the last, 15 to 16 months, where patients are just coming to their appointments and just outright crying. Not something I didn't see before, but just people already just like on edge at any moment. And with someone just asking a simple question of like, how are you doing? Which 2 years ago would have elicited a response of just like, okay, well, I'm fine. even though things were not fine then, the how are you doing question now is really hitting home of like, you know what, no, I'm not fine. I have all of these problems. I don't know what to do. And I'm not finding myself with the ability to cope. And they're being open about this because you're seeing that other people are expressing this as well. You know, it's kind of like if we're all in the suffering boat, you know, you don't feel yourself as being singled out for how you feel. So I do think that's sadly, a good thing that's come out of this is people finally giving a name, albeit sometimes not wanting to. Like, people don't want to own the label of depression, understandably, for many reasons. I feel many of them culturally, to be quite honest. But we're getting somewhere, right? We're moving a little bit ahead with this.
Yeah, that's great, Ornella. Maybe we can now hear from Dr. Chaudhry. So as mentioned in the Kaiser Family Foundation study reference and from others on the panel, we've seen an increasing number of people experiencing anxiety, depression, other mental health conditions. It'd be awesome if you could elaborate a little bit on the type of work you've witnessed in working with your specific population, the American Muslim community, and some of the solutions that you're working through.
Sure. And, you know, in my role with the American Muslim Health Professionals, we do work to understand our community, but a lot of our work is also interfaith related and work with other ethnic and religious minorities. And so we draw a lot from our surveys with those communities and partner organizations. And also in my role as director of an asylum and refugee clinic at the George Washington University, we can kind of find more about the immigrant communities that are really working through how their lives have been affected post-pandemic, and you know, and how that results in the mental health concerns they are experiencing, how that's changed. A lot of this, you know, is sort of surrounding this notion of how we connect as communities, and that mostly, you know, has to do with that interfacing of other religious in places of worship, religious centers, interfacing in cultural community centers. That completely came to a halt, as we know, and that happened for many people. But what I've seen in the work I do with the clinic at George Washington University and then American Muslim Health Professionals research and findings through their work with other interfaith groups is that has been such a crux of the mental health experience that resulted in that loneliness, that loss, that emotional disconnection from those friends and family members. And then, of course, their religious and cultural figures that they received a lot of guidance from, a lot of connection to how they work through mental health issues, where they weren't seeking that necessarily in a formal treatment. And so that really was a significant impact in those communities. And a lot of imams and people who are not at the centers, or the centers themselves, are sort of asked to come up to the front lines of mental health crises. And that is a kind of experience that was really unprecedented. And then that also relates to how Muslims grieve and how Muslims are dealing with loss in economic terms. And then, of course, real grief that has to do with the grief of the loss of loved ones. That connection to the process and the ritual of that was really just broken in a sense, and they had to find other ways. And now some communities were really creative about that, but a lot of communities reported experiencing a lot of complicated grief issues around this, that they couldn't go through the experience of burial and process of grief. And that might look as though it's a process of grief that is prolonged, but many people really, when you look through the research that such as ISPU, which is Institute of Social Policy and Understanding, did, they experienced it as symptoms akin and kind of lined up with complicated grief, because that process is so critical to that experience of being a Muslim. And then, of course, the work I do in the asylum clinic has really found that people who have had such prolonged disconnections from seeing family already abroad, and then a disconnection here in the United States to a cultural center or group, has really found that there's that rise in depressive experiences, an experience of more crises we've seen in the clinics. So it's kind of been a, when you get into the diverse groups of immigrant, refugee, ethnic, and religious minorities, there's a sense of not being able to go where you really normally felt. There was some solace and communication of what you experience, and then also really not having a set up system to seek treatment and seek something that was, available to you. When we were able to transition to remote work, of course, in our clinic, and then of course we've had Muslim practitioners around the country, we've done that to the best of our abilities, but as a community, but that is culturally laden, right? And so access to resources is a culturally bound experience. A lot of people are not familiar with that. They're not going to just transition into finding a clinic or a center that's remotely offering service when maybe they've never even received services before. And then there's barriers. There's a cultural barrier of how do you get through a mental health, how do you communicate the mental health experience that you have an incredible stigma within your own community dealing with that, and then go past those other pieces to even try to absorb that in a remote way, learning how to do that, being able to have the resources, the private space. Many families do not have that. Many families in the American Muslim communities and then immigrant and refugee communities that we've seen. I do want to make an important point that COVID demonstrated, as so many people have spoken already, something where things really were highlighted and amplified that were already existing. For the American Muslim community, what's so important is to recognize that cumulative trauma that has been ongoing for many years in the American Muslim communities and local settings, where you have an experience that we have now know results in really daily kind of micro experience of trauma, of Islamophobia here in the United States and abroad. This really amplifies people's difficulty of seeking a service and trying to go into a mental health system and move through that and feel as though people are really looking at the mental illness alone and not combining that with other preconceived notions about Muslims and feeling that they're sort of struggling with the daily microaggression that they might experience, but then also real trauma they experience or more deeply laden trauma, and then seeking service for that becomes a complicated process. And really that results over time in an experience of I would say a trauma that a lot of Muslims feel they experience, through in multiple settings. So you want to kind of understand that. And then the diversity of our group of Muslims is not homogenous. We have Black Muslims, 25 to 30% of Black Muslims are part of our community. And they experience that kind of daily traumatizing experience of their identities being questioned at some level that has to do with their mental health experience. It results in that mental health experience being not really seen as important as they are, and what the cause of their experience is, and it's multiply determined. So that's kind of what we are working with in our communities and trying to get down to really moving through as much research as we can and garnering as much research as we can on.
I think that so many great things you shared. And there are two words that kind of really stick out. And I think, and I don't want to sort of say it's like a bandwagon term, but I feel like this notion of trauma is becoming more prevalent. And Maddie's point earlier is that, half of the large number of people are under the age of 18. So people that are youth that may have experienced something early in their life, that sort of those things start to trigger and come out in their teenage and older years. And as you said, Dr. Chaudhry, this can be also culturally laden. So would love to hear what everyone's thoughts are on the importance of trauma-informed care. What sorts of solutions and innovations or sort of models are you seeing emerge from this, or you would like to see more attention addressing this sort of way of providing care?
Yeah, I mean, I can make a couple of comments. I mean, I think that we're highlighting a very important point here, that the pandemic has simply magnified a situation that was already there in terms of, the disparity of the availability and use of services to support mental health, and how I think the communities that, first of all, I think we're all aware that trauma plays an important role in the development of mental health challenges, both on an individual and a collective basis. And I think one of the challenges is that the populations and communities who are experiencing the most trauma, one of the questions we had mentioned, the racism and police violence in the Black community. Ornella highlighted the challenges and the anxieties that undocumented immigrants feel. Dr. Chaudhry mentioned, some of the stereotypes and perceptions that are leveled against the Muslim community. These collectively have an impact on communities, on the very communities who have reduced access to the kind of support that they need for those kind of the mental health issues that result from those traumas. So if you look at the literature before the pandemic, it does recognize that, but it highlights that, alongside some innovative approaches to, providing those healthcare services, including sort of incentivizing policymakers and administrators to target disparities in the provision of healthcare. It also highlights the fact that education and awareness is just as important, that, we need to, especially within certain communities, normalize conversations about mental health challenges, and help people understand that these are not conditions which there needs to be a stigma about, and that there is help and support available. So I think the educational efforts, the provision of services has to go hand in hand with the educational efforts.
I can jump into, I think one of the things that I was thinking about as Dr. Chaudhry and Ornella, you were speaking, and Doug, as you just touched on, one of the things in the immediate term that I think can make a really large difference is more investment in peer support specialists and community mental health workers to help mitigate workforce shortages, but also to serve as that connection. And I think I was thinking about this with Ornella, you mentioning the power of seeing people talk about in your community, talk about your own stories, and how that it makes people feel safer to talk about theirs and to bring up if they need care. And Dr. Chaudhry talking about the cultural barriers of connecting with a clinic, how to know where those things are, and how to connect with treatment and services. And I think peer support specialists can absolutely play the role of helping people in their own communities connect to and stay engaged with services and navigate complicated systems and really support people who are often isolated, and connect people with a community in person who understands what they're going through. I think that can really help to provide support, especially in integrated settings and care teams, to reach people before they reach a stage of crisis that they really need mental health treatment, and again can provide that culturally or linguistically appropriate or responsive care that may not otherwise exist. So there's really an opportunity now to develop a peer workforce that reflects the communities to be served and understands their unique mental health needs by expanding access to recovery services.
One thing, if I could just add, touching off of this idea of trauma-informed care, which is super important, I'm here for it, but I feel it's also time to begin calling out culturally informed care, culturally influenced care, culture-specific care, and this idea how you have to take the historical context of different communities when you think of the care appropriate, for them. And with this, I also, semi-soapbox moment, but go on me with this journey, everybody. I want to just pull back, just the current, just a little anecdotal point I want to mention, and trust me, it comes back to all of this. I've been in a few meetings with different, specifically mental health directors and executive directors here in the Chicago area. And one thing that has been mentioned multiple times by numerous sites is how they have many open positions. So on the one hand, we don't have enough providers, but on the other hand, I'm hearing what? Not one position, I'm not talking two, I'm not talking three, I'm talking sometimes more than 5 open positions for mental health clinicians at what are FQHCs. And when you think of the community that is served by FQHCs, I think if I'm thinking of culturally specific care, I want people from those communities with their own communities being providers. And if you think of the nonprofit sector, and when you think of, I'm speaking for myself, as a Latina, if you're being the first in your family, for example, to get a college degree, to go on to graduate school, what is the incentive to say, you know what, I'm going to take a massive pay cut and work at this nonprofit just because I want to help my community? Now, for many of us, it's in our blood. We have a commitment to serve our communities, but there are these conflicting cultural issues of like, do better, go on to better, make this good money. However, with that, where are those folks going, right? Are they going to the community centers, which sometimes pay less and really do pay less, but it's for the greater good that we work at these sites? But I say this all to say, there's a reason why there are openings. And until we can find a way to better compensate, shadow for the state to hopefully do something about this, right? And truly recompense different organizations and clinics and systems to compensate the workers, the type of workers that we need, like we need to put an incentive in the system for our community to help our own communities thrive. And I say this is all connected because when I think of culturally influenced care, I know exactly why there aren't enough culturally specific staff to help all the clients that I would want to be helped by services. So thank you for going on that journey with me, y'all.
Ornella, I think that's super valid. And I think that it's especially true to have, culturally sensitive and culturally, people from your community addressing these issues with you. But I want to ask everyone, I think that this is just a great broader issue that we have a lack of people wanting to take these jobs because they don't pay very well. So like Ornella said, do you fall on the sword to serve your community, or how do we encourage, and what sorts of, either do you think it's a private thing? Do you think it's a policy thing? Like, what are the types of things that you think that we can do to advocate for how we actually prioritize this? Because our workforce is the backbone of of addressing these issues.
Is it for me?
For anybody that wants to jump in with like how we, running up the flagpole to DC, that we need all those dollars to go back to mental health.
I will say, just aside from money, things like even reimbursement for just, school debt, right? Like find a way, find something, or helping to cover CEU costs for all of us who have license, right? Like there has to be something, because kudos and congratulatory sentiments are fantastic, but money is a phenomenal way with which to show appreciation. And oftentimes that can make or break many programs, and sometimes the best of programs.
Yeah, going back to peer support specialists, absolutely. Or Ornella, I want to put a plug in. There's actually a bill in Congress right now. It's HR 2767. I hope I got that right. I will try to put a link in. But it's to provide Medicare coverage of peer support services for individuals with mental health or substance use disorders who are being treated in primary care. And it's absolutely for that, because A lot of the time, peer support specialists are not paid a living wage and aren't being reimbursed appropriately where people can even go into these positions. And so that's exactly what this particular bill is trying to do, is it expand coverage of those services under Medicare. I think that would make a huge difference to actually pay people to be able to work in those positions and live.
Great, Maddie. I can't believe you were able to say that off the top of your head. I'm gonna pull out an audience question, because thank you for everyone who's writing questions in the chat. So Doug mentioned it, and I'm wondering if others have things they want to elaborate on, but Greg had asked, given the timing of the pandemic being layered on top of racial justice uprisings, greater public awareness of police brutality against Black and Brown people, increased violence towards AAPI communities this past year, plus how can we address the complexity of these factors, including racism's impact on mental health? Not sure if someone wants to start that one.
Maddie, can you repeat the last end of that? I didn't hear the last part of that question.
Yep, so just given all of the things that have happened in the past year, racial injustice and police brutality, how can we address the complexity of these factors, including racism's impact on mental health?
I mean, I don't mind just starting there, and I would really want to give anyone a chance to kind of jump in. You know, we talked a little bit about this notion that mental health, you know, for certain minorities and communities like Black Americans, Black Muslims, other ethnic and religious communities, Latino, Hispanic, you know, there is an experience that Black and Brown people have where mental health is not fully appreciated as part of their experience. And there's something that that just, it gets stymied, I think, when it becomes a sense that people experience racial injustice, but there is not a direct correlation necessarily in people's minds that mental health is part of that. And that, you know, recovering from one racism related incident takes time. And then there's another one, and then there's another one. And then that experience of recovery is not there. And over time, as we know through our own health research, as everyone likely listening and has read and been part of the discussion, is over time that results in that cumulative trauma experience. And something about that is, you know, unfolds in a mental health experience, an issue, or a you know, a crisis, because there is that lack of recovery time from this. And so then the mental health, it's something that health organizations are struggling with, as well as others, and every, you know, individual in society to really recognize that the mental health experience of these communities, it must be recognized as part of the picture, so that there's not a lack of appreciation of that. And then when individuals start there, whether you're not in health or you are, if you're a teacher, if you're a civic organizer, or anybody that has some connection to community, when you recognize that, you know, then other people really can follow along and begin from there. And I think counselors and therapists really getting into that literature and understanding is the place to start. I think Doug talked about education and awareness. In my experience, there is a deficit there in fully appreciating that Black and Brown communities have a mental health experience that is not being recognized around this social experience they have and their experience in this country.
I also want to add, just really quickly, this message came from Greg, and I know you didn't ask for this, Greg, but if any of you want to check out a fantastic organization that has actually been doing this good work, please do check out Yoga Care, really great organization. They have also partnered with Community Health in the past. Just want to put that out there. But again, they're really great. And, you know, they are very much addressing those issues. I see it every time with the emails that I get from them, the work that they're doing specifically around this. And one thing that I hope, I have not seen much of it during the pandemic because of just pandemic times, and also just how off-putting a lot of the virtual Zoom experience can be, no offense to us all. But what I do hope to see more of, which there was some of before, but I hope to see more of, is just like more, whether you want to call it group support, peer support, whatever you want to call it, but this idea for people to be more in talks about the shared experience of disenfranchisement, racism, stigma, of just like, why do they always see us as the complainers? Why don't people see the real issue we're talking about, rather than just saying we're violent, we're this, we're that? And I say this because, though I'm not saying changing the system is too hard, which it is, but this idea, I feel that, you know, to heal at like the very personal level, it's so much easier to begin that healing if you have the peer support. And I really hope to see more of in-person programming just in general, but specifically from, again, you know, people within our own groups, you know, who are having this disenfranchisement, who are facing this racism day to day, who perhaps, you know, have not had this experience before, but now, I mean, now it's here. It's really hard to ignore. So I really hope that through more supportive group opportunities, we can amass more change. Because at a certain point, if you have all kinds of, let's say, youth groups and adult groups talking to this, there will be this massive, you know, coming of like, we have all of these thousands of members to then go to the city, go to the state, what have you. And, you know, these are our collective requests. Just a starting point.
Yeah, that's awesome, Ornella. Thanks for that color. All right, so we've got 6 minutes. Before we wrap up, I want to give each of you the opportunity. Okay, let's imagine we're 5 years in the future. I'm going to give everyone 30 seconds to tell us where you would like to see the state of mental health services in 5 years and what you think it would take to get us there. So let's start with Doug.
I'd like to see, you know, at a sort of individual level, I'd like to see conversations about mental health become and feel as normal about as conversations about any other kind of health. You know, I broke my thumb recently, and everybody asks me what happened to my thumb. I tell them what happened to my thumb. They don't say to me, well, have you tried just not having a broken thumb? You know, maybe that would help. So I think, you know, we all ask each other how we are, but I think we need to start kind of meaning it, normalizing these conversations to say, you know what, I've been going through a tough time. You know, I don't really want to talk about it, but, you know, and normalizing kind of getting help for it, and making those conversations just matter of fact instead of a big deal.
That's great, Doug. Let's go to Ornella next.
In 5 years, I would hope, my wish upon a star answer is, I hope to see much more pairing of mental health services with other social support services, as I mentioned early on, with more housing opportunities, more workforce development, safer neighborhoods, just everything possible. You know, mental health is not standalone, will never be, and without the support services, this cannot move forward. So I do hope to see more pairings of just the vast support services that can be available to communities in conjunction with mental health services as well.
Awesome. Maddie, and then we'll close out with Dr. Chaudhry.
Yeah, I think I would like to see a system that's dedicated to identifying and addressing mental health concerns as early as possible. We're kind of, the way we work now is by triaging care a little bit, because we are so strapped for resources and infrastructure to people in current crisis. But we need to invest in more population level mental health measures and integrate mental health care more into where we live and work, in schools. So I think things like the implementation of universal mental health screening, building in comprehensive mental health education early in schools, and investing in those connections with community-based services. I'd also like to see, Doug mentioned this very briefly earlier, but I would like to see a system that prioritizes mental health surveillance and data collection the same way that we've invested in other areas of public health. So looking at that real-time population mental health monitoring with more representative research and more representative data. And finally, my last thing, I promise, I would like to see a system that's really centered on asking people what supports would be most useful to them. So really listening to individuals with lived experience in communities, not just listening to advocates or providers in those communities, and creating systems of supports that really respond to their needs. So that even means going beyond listening and start giving power to those individuals to create their own supports, and investing in those informal or previously underfunded providers or other assets that already exist in communities.
Last but not least, Dr. Chaudhry, you have the last word.
Thanks so much. I think that in 5 years, I'd reflect on the work that we've been doing, which is in AMP, American Mental Health Professionals, we've partnered with the National Council of Behavioral Health to train as many interfaith communities as possible in mental health first aid. So we really believe in innovative approaches to mental health today, and in the last few years thought about that deeply, that we've got to go beyond the kind of understanding we have of how to improve the mental health and experience and help seeking that we've already seen. So we want to train as many people as possible in the mental health first aid movement. And so in 5 years, I hope that I'll go really big and say, I hope that every individual American is trained in the MHFA program. That's my vision and ambition for the United States and for all communities that care about that and feel it's a part of their daily life.
Well, I'm on board with this wish list, and I think we all should make this happen. A huge thank you to all of you, Ornella, Maddie, Doug, Dr. Chaudhry. It's been such a pleasure to have your insights, and we're really appreciative of you taking the time and sharing your recommendations for how we can really empower all of us to be better mental health advocates in our communities. And a big thank you to all of you that joined us today. We look forward to staying connected and hope to see you at upcoming All In Chicago events, which our big series is this September. Again, you can learn more about those events and more about the campaign at allin-chicago.org. You can also learn more about community health at communityhealth.org. And we are just tremendously grateful for all of your support in these conversations. And that's the only way that we get this done, is we keep talking. So thank you for joining us today. Have a wonderful rest of your day. We'll see you next time. Bye.